The next topic is going to be a discussion around desensitization and ABO incompatible transplantation. I should be able to move quickly through that topic. That's not a common intervention in transplantation. You should know some basics about it. So HLA incompatible transplants are when I transplant a recipient, right? If I have a recipient who is producing, my recipient is producing, for instance, an anti-A2 antibody, right? And I have a donor kidney which is expressing A2 on its surface. Remember, that is an MHC class 1 molecule. A and B are class 1, DR, DP, DQ, those are class 2. Hopefully you remember that. Class 2 molecules are expressed by the antigen-presenting cells. Class 1 is on all nucleated cells. So again, an HLA incompatible transplant is when the recipient has preformed antibody to donor HLA. Okay. ABO incompatible transplant is when I have an individual who is a blood group A individual, which means they're producing antibodies to B, right? They have anti-B antibodies. And if I try to transplant a donor organ from a blood type B individual, then that would be considered ABO incompatible, right? Okay, so let's discuss this in greater detail. These are higher risk transplants, okay? This is something that you would consider when you have living donors. We generally are not doing HLA incompatible or ABO incompatible deceased donor kidney transplants. This is when the individual is highly sensitized or doesn't want to wait on 5 years on the wait list for a cadaveric kidney, but their wife wants to donate, but just is incompatible from a blood type standpoint. The alternative to this is these paired kidney exchange, right? If you don't want to do these ABO incompatible or HLA incompatible transplants, the alternative to this is to do something called paired kidney exchange. What is that? Paired kidney exchange is when, let's say, this donor and recipient pair, right? Let's say wife and husband are incompatible, but another donor and recipient pair also has some incompatibility. And so this donor donates to this recipient, and this donor donates to this recipient. That's paired kidney exchange. These chains of donation can be quite long, where somebody donates to somebody's loved one, and this exchange of organs has a sequence of consecutive transplants that's like 15 patients long, right? They try to do these close in time, because if you break the chain, if somebody says, well, I changed my mind, that is a big deal. So you don't want people to have a month to think about whether they're still planning to donate, right? These are generally done synced in time, very close together. Okay, so if you don't want to do paired kidney exchange, this is another way to cross some of these barriers with living donors who don't want to wait for cadaveric kidneys. Okay, sometimes it's with a highly sensitized patient who doesn't really have many options, even with cadaveric kidneys. Okay, so the risk of this incompatibility is not the same across donor recipient pairs. The highest risk ABO or HLA incompatible transplant is a transplant, a prospective transplant that has a positive cross match on the cytotoxicity cross match. Okay, you have to remember, what is a cytotoxicity crossmatch? We talked about some of these things in an earlier discussion when we approached the initial topic of transplant immunology, right? A crossmatch can be positive based on flow cytometry, which is what we do as routine in our transplant center. Flow cytometry means I have a donor lymphocyte, right? And I have recipient serum, right? That may have preformed antibody to a class 1 molecule. This has a antibody with a fluorescent tag. So I mix donor cells, recipient serum, a reporter antibody, and then I count whether it's positive on a flow cytometer. Okay, this is pretty sensitive. On the other hand, a cytotoxicity crossmatch is, if you recall, mixing donor cells, recipient serum, and then rabbit complement. And this looks for sufficient antibody to be present from the recipient that I can even activate complement. Complement is activated, and then this cell is lysed, right? So it pops, okay? That's a cytotoxicity crossmatch. That means you have a lot of preformed antibody. It's not just enough to light up a flow cytometer. It's enough to fix complement and lyse cells. That would be an individual who's at risk for hyperacute rejection in the OR, right? And that's a pretty tall barrier to try and surmount. In general, nobody does HLA incompatible transplants between two individuals where there's a positive cytotoxicity crossmatch. Okay. It's usually reserved for people who have a positive flow cytometry crossmatch, but the negative cytotoxicity crossmatch. Okay. Now, there's an even lower risk individual who has incompatibility by a Luminex study, okay? But even the flow crossmatch is negative, okay? So Luminex is even more sensitive than this flow crossmatch. Remember, Luminex is, I have beads that have a class 1 molecule on it. I mix this with recipient serum and I look for a positive signal. This bead is highly expressing the interesting class 1 molecule that you're evaluating preformed antibody to. This is a more sensitive test than even your flow crossmatch. Okay, so this would be because and this, so I'll just leave it at that. So that would be a lower risk HLA incompatibility to try and surmount. Now, keep in mind, remember basic principles of immunology. If I have even a low titer antibody to something like my donor organ or a coronavirus, right? I have a plasma cell in my bone marrow, a population of plasma cells in my bone marrow that can expand and I can produce lots of antibodies, right? So that's the amnestic response to infections that we leverage. We're not constantly circulating high levels of COVID vaccine stimulated antibody, right? It wanes, but I have this plasma cell ready to go. You sensitize that plasma cell, you give it a positive signal. Yes, I now have COVID. It can now expand and produce huge amounts of antibodies. So this is still a barrier, but it's the lowest risk barrier, right? And it's not a situation without risk just because your flow cross-match is negative. Okay. Clearly, long-term outcomes for HLA incompatible transplants are worse than for HLA compatible transplants. And this is just basically saying the statement that you lose the survival advantage of living donor kidney transplantations. They might have similar allograft survivals as a deceased donor kidney transplant. Okay. ABO incompatible transplants, again, are when there's incompatibility between donor and recipient at the blood group level. Now, you have to know something about expression of A2 of A antigens on cells. Okay, so blood group A is unique in that not all individuals express large amounts of A on their tissue. Okay, so some proportion of blood group A individuals have the so-called A2 antigen. It is actually probably more appropriate to say non-A1 blood group A because there's more than just A2 as an alternative to the traditional, more common A1 antigen. Okay, so, but, most of non-A1 antigen is A2 antigen. A2 antigen has less expression on tissue. So there's just less A2 on the tissue. And what A2 is present is less antigenic than A1, okay? Meaning less able to be recognized by anti-A antibodies. These antibodies to blood group antigens are called, as a class, isogluten antibodies. Okay, those antibodies to blood groups are called isogluten antibodies. Okay, so again, when you express A2 on your cell surface, the anti-A isogluten, okay, is less able to bind that, both because A2 is just less avidly bound, and also A2 is less expressed on tissues. Okay, so there are certain individuals that can accept these A2 donors, even though they're blood group B. Okay, so a blood group B individual can theoretically be receiving an A2 donor kidney as long as they don't have large quantities of anti-A antibody, isogluten antibody. Okay, that is now built into the organ allocation system. You don't have to be a specialized center that is willing to cross ABO barriers in order to take a A2 donor kidney into a B recipient. Okay. All right. There's some special testing that's done. Again, what happens is these blood group B individuals can get an anti-A titer measured, and if it's low titer, then they can be listed to receive blood group B kidneys, blood group O kidneys, and blood group A2. Okay? Make sense?
So the antibody is common.
The isogluten antibody that binds A generally can bind A1 and A2. It binds A2 less avidly, and A2 is expressed in less density, at less density on the surface of tissues. Hence, we can cross that barrier without doing desensitization protocols. Okay?
In other words, A1 donor will never be considered as ABO incompatible transplant. Only A2 donors are considered.
No, so you can be a specialized center that's willing to cross an incompatibility with A1. okay? But that would take extra protocols of apheresis and IVIG and all of that stuff. But if you want to cross an A2 barrier, you don't have to do that. As long as your isogluten titers for A are relatively low at baseline. Okay? All right. These patients do have risks of antibody-mediated rejection to these blood group antigens. Okay? But generally, these can be surmounted more easily than ABO incompatibility. Okay? People who have done this seem to be locked up for some reason. Uh-oh. Yes, these long-term allograft function seems to be similar to ABO compatible transplants. So that's less of a barrier to cross than HLA incompatibility. Okay. All right. So continuing on. In general, when I want to cross these barriers, there's a variety of protocols, right? But we're looking at HLA antibody titers or isogluten titers in order to make an assessment of the risk of this incompatibility, and then responding in kind, right? Sometimes we just we don't even try because your titer is too high, or you have a cytotoxicity cross-match that's positive, and so that barrier is just too great, right? So often titers and cross-match are what determines whether this is a barrier that we can consider crossing. Protocols that you might see generally involve apheresis pre-transplant with varying amounts of IVIG, monitoring titers, sometimes giving rituximab. In rare cases, we're doing splenectomies as a way to reduce plasma cell populations. We're generally going to give heavy immunosuppression, so you're going to do thymo or campath in order to try and cross these barriers. And then post-transplant, you'll also do apheresis and IVIG monitoring isogluten titers. Similar for HLA desensitizations. There are also protocols where you can just use high-dose IVIG without necessarily apheresing an individual. Remember, I think we talked about how IVIG can cause that feedback inhibition on antibody production by a plasma cell, right? Flooding the Fc receptors of a plasma cell with immunoglobulin can downregulate its production of antibody, okay? Often there's going to be protocol biopsies that are done when you're trying to cross these barriers to try and recognize rejection earlier and then treat it quickly. Okay. If you want more detail on these, I invite you to read more. I would say, again, this is a pretty uncommon niche of transplantation. So I'm going to kind of move on to other topics. Any other questions?